This is Sally Schessler, the Director of Education for Allergy and Asthma Network, and I am pleased to host today's webinar for Allergy and Asthma Network. Our mission is to end the needless death and suffering due to asthma allergies and related conditions through outreach, education, advocacy, and research. We welcome you to the first webinar in our 2019 webinar series titled Advances in Allergy and Asthma. Today, we are pleased to be joined by Dr. Michael Pistiner, who will share with us about anaphylaxis for the infant and will discuss the special considerations for this growing population. Dr. Michael Pistiner is Director of Food Allergy Advocacy, Education, and Prevention for the Mass General Hospital for Children Food Allergy Center. The MGHFC Food Allergy Prevention Program serves the infant and toddler population and includes the Infant Food Challenge Unit and the supporting clinical and research activities focused on this population. He has a special interest in food allergy and anaphylaxis education and advocacy, infant food allergy management, healthcare provider education, and facilitating collaborations between the medical, home, and school health, and maintaining quality of life in children and their families with food allergies. Dr. Pistiner is a fellow in the American Academy of Pediatrics, where he is a member on the section on Allergy and Immunology Executive Committee, Council on School Health, and the Massachusetts chapter of the AAP. He is also a member of the American Academy of Allergy, Asthma, and Immunology, and the American College of Allergy, Asthma, and Immunology. Additionally, he serves on the Medical Advisory Board of Allergy and Asthma and Allergy Foundation of America, New England chapter, and is a voluntary consultant for the Massachusetts Department of Public Health School Services Unit. He's author of Everyday Cool with Food Allergies, co-author of the Living Confidently with Food Allergy Handbook, and co-founder and content creator of allergyhome.org. Dr. Mike, we really look forward to the information that you have to share with us today.
Thank you, Sally. Now, I'm unable to advance the slides so far.
Okay. Well, it worked just a few minutes ago, didn't it, when we were talking about that? Do you need to close out of them and come back in, or how do you think that would work best? Oh, there you go.
It's working now. All right, great.
Wonderful.
Well, thanks so much for having me. And everyone, thanks for joining us. We have a group of parents and healthcare providers, including nurses and physicians and clinicians. And so we'll be talking today about anaphylaxis of the infant and special considerations for this growing population. I'd like to disclose that I'm co-founder and content creator of Allergy Home and Allergy Certified Training. I serve on advisory panels for Kaleo and DBV. I am recipient of an unrestricted grant from DBV, and I don't intend to discuss any unapproved or investigative use of commercial products or devices in this presentation. Superman is the epitome of health and the epitome of strength. Like kids, he's seemingly unstoppable and he's faster than a speeding bullet. Like teenagers, he's a snappy dresser and he thinks he's invincible. Like people with food allergies, something that is seemingly harmless to others can make him sick really fast. This is my Superman. This is Scott, my son. He's now 15, and when he was 3, he had his first allergic reaction to a walnut. That was his kryptonite, a chocolate bar with walnut in it. We gave it to him when we were in the grocery store, and he ate it, and he thought it was so delicious. Within about 30 seconds, he told us that he couldn't get the taste out. That's when I looked at my wife and I said, I think he's having an allergic reaction. I was a second-year fellow at Children's Hospital, Boston at that time. She looked back at me and told me to shut up because I was such an allergist. About 2 to 3 minutes later, he got cranky, irritable, and he started getting really kind of scared. About 10 minutes later, he vomited. Big mess in the fish department. 20 minutes later, he started getting sniffles and his nose started to run and he started to sneeze. His ears also started to itch and he started scratching at those. After about 25 minutes, he started to have some throat clearing and some dry coughs. And 30 minutes later, he started having hives. That's when my wife looked at me and told me she thought he was having an allergic reaction. So what was that? That was anaphylaxis. That was a severe life-threatening allergic reaction. Now, at that point, Scott was 3. He was able to say to his parents what was going on, but there was still some ambiguity. It was still challenging, and it wasn't quite so obvious until he started having some additional symptoms. But what about the infant? Infants can't talk. They can't tell us, parents, what's going on. We can't speak to them and communicate. So there's going to be other ways that we're going to have to be able to use to tell if our children are A, having an allergic reaction, and if they are, is it severe? Is this potentially anaphylaxis? So the goals of this talk are to discuss the community management of food-induced anaphylaxis in the infant. So since we have 2 kind of large groups here, parents and the caregivers, and then also healthcare providers, what I'm hoping for is for the parents to give you guys the confidence to be able to get comfortable recognizing and treating anaphylaxis in your kids. And for the healthcare providers to help give you the tools to be able to communicate to your patients and to be able to teach them how to appropriately and confidently manage anaphylaxis in their kids. Also, to give you pearls in your own experience within the clinic setting if and when you are having anaphylaxis, especially for some of those on the line who are allergists conducting food challenges, then some of the pearls in the experiences of dealing with infants will be very helpful. And again, communicating these to the families that we all care for is the point of all of this. Now, please note that the specific office food challenge, inpatient and emergency department anaphylaxis management is beyond the scope of this. And so we're really targeting community management here. So I'm going to kick things off by talking about 2 myths. The first is that it's wise to delay the introduction of highly allergenic foods. Now, this was the thought for years. Back in 2000, the American Academy of Pediatrics released a statement that said solid foods should not be introduced into the diet of high-risk infants until 6 months of age, and eggs should be delayed until 2, dairy until 1, peanuts, tree nuts, and fish until 3. After those recommendations, food allergies continued to rise and rise quickly. Typically, at that time, many children weren't being evaluated by allergists. Many children were not having the highly allergenic foods in their diet. And typically, allergists weren't seeing kids until they were older than 2. Another myth was that skin testing was something that you wouldn't do in anybody under 2. And again, with that, many allergists were not collaborating with pediatricians in the management of kids with food allergies. And at that time, feeding recommendations were not what they are today. Now, in 2008, the American Academy of Pediatrics rescinded those 2000 recommendations. The 2008 recommendations now said that solid foods should not be introduced before 4 to 6 months of age, but there was no reason to delay other foods, and that delaying it could actually cause a problem. But with that 2008 report, it didn't specifically say when and how to give. Now, many allergist offices were not ready to be taking care of infants, and many of the staff haven't really managed too many kids under age 2. Relatively recently, some strong evidence has come out that in kids at high risk of developing peanut allergy, if they aren't already allergic, then early introduction of peanut can decrease the risk of developing peanut allergy by 80%. With this study, the LEAP study, came guidelines NIAID guidelines, the National Institute of Allergy and Infectious Disease, that made formal recommendations for when to recommend peanut in both high risk and kids who aren't at high risk of developing allergy. Now, this clearly has brought younger patients into the offices of allergists and has started these conversations in pediatric offices much earlier than they have in the past. So these NIAID guidelines state that in kids with severe eczema and or egg allergy, that they should have some screening before starting peanut, but the target time to get peanut into their diet in a baby-friendly way is between 4 and 6 months of life. Now, in kids who weren't at high risk, so kids who didn't have severe eczema or already had an egg allergy, then pediatricians and pediatric teams would be recommending early introduction of peanut-containing foods. Now, keep in mind, no loose nuts until age 5, and it would be smoothed out. Peanut butter is one of the forms, and about 2 teaspoons 3 times a week would be the target. And in kids who weren't at high risk, then the target time's around 6 months, and no screening necessary. These would be kids who would just do the introduction of the foods. Now, while these guidelines apply to peanut, they don't specifically talk about the other foods, but we do know that delaying the introduction of the highly allergenic foods is not helpful, and similar recommendations now are starting to have evidence behind them that early introductions for things like eggs are also beneficial. So now we have this new infant population that is showing up in allergist offices, and we're also having these early introductions. So we're starting to see some food allergies earlier than we may have years ago. So we're having all these introductions of these foods, and so kids are starting to show up with some of these food allergies. And so our offices are starting to see kids who have allergies to peanut, as the guidelines are bringing children for evaluation for peanut, and also subsequently egg allergy and other foods as well. So we're starting to see more and more babies and infants with food allergy. And what we're also finding is in the LEAP study that I mentioned, and I'm going to just go back to these slides for a second, in the kids who did have allergic reactions, they tended to have more mild reactions than when they were older. So at the time between 4 and 11 months of life, if they were to have an allergic reaction, these kids tended to have more skin findings and mild symptoms as opposed to more severe symptoms. And the children in this study, the infants in this study, didn't need epinephrine and did not experience systemic anaphylaxis, while when they were older at age 5 and they experienced allergic reactions, more of them required epinephrine and had respiratory and cardiovascular symptoms. In the past, people were afraid that in these nonverbal children that they wouldn't be able to communicate their symptoms, and that perhaps they might be having more severe symptoms. And so people had the tendency not to do food challenges in them, where now we're finding that the earlier we can follow these recommendations and guidelines, we really can decrease some unnecessary food allergy in these children. All right, so what is an allergy? An allergy is an abnormal immune response to food protein. Now, what we're specifically talking about here is IgE-mediated food allergy. IgE, immunoglobulin E, is a protein that is within our body and sits on our mast cells and basophils and also can be found elsewhere. In the case of peanut, for example, if someone has an allergy, they will make IgE to peanut. If peanut protein binds with the IgE, then this can cause an allergic reaction because then these mast cells or basophils release what's inside, causing symptoms of allergy. Now, what's inside these allergy cells, these mast cells and these basophils, are things other than just histamine. Proteases, lipid mediators, cytokines, proteoglycans. Once these are released from these cells, this can cause some of the signs and symptoms that we see in our patients, that we see in our children. Now, these mediators of inflammation can cause GI symptoms. They can increase fluid secretion. They can increase peristalsis. That's the movement of our gut. That diarrhea, that can cause vomiting. These mediators of inflammation can also affect our airways. They can cause increased mucus secretion. They can cause decreased diameter of our airways, and we can see wheezing, and we can see coughing, and we can see phlegm production. We also can see congestion and nasal congestion and lots of discharge coming from the nose. Now, blood vessels can be affected because they can get permeable, they can get leaky, and fluid can leave from them. Also, the vascular tone, the muscles that keep the veins tight, can also get loose and floppy. And what we can see is we can see leakage of fluid from the intravascular space inside the blood vessels to outside, and that can cause swelling, and that also can cause fluid loss. So each person, each kid, each infant can have different symptoms from others. And each person can also have different symptoms with a food reaction in the same person to another time that they have another food reaction. You can have several, you can have all, you can have one. So getting used to the pattern of what it can be is going to be important for the provider of a child with a food allergy, especially an infant who can't communicate. So in the skin, we can see hives, swelling, itching, warmth, redness. Respiratory-wise, coughing, wheezing, shortness of breath, chest pain or tightness, throat tightness, trouble swallowing, hoarseness of the cry or voice. We could see nasal congestion, where somebody might not be able to breathe through their nose, so they'll start breathing through their mouth, or they might not be able to suck their binky because they can't breathe through their nose. Sneezing, hay fever-like symptoms. GI-wise, we can see retching, we could see kids doubling over in pain, we could see vomiting, we could see diarrhea. Cardiovascular symptoms, in an infant, we might see somebody who loses balance, loss of consciousness, paleness, blueness, very lacy appearing skin, and we can see kids get really lethargic and lose consciousness. And in little ones, we can see crankiness and irritability, where older kids and grown-ups might explain their symptoms of the feeling of pending doom. Now, you'll notice that I'm going to keep coming at these symptoms from different angles to try to get you comfort with recognition and seeing some of these patterns. Now, the majority of these IgE-mediated reactions that can result in anaphylaxis occur within a few minutes to a few hours after the exposure. Anaphylaxis, as I mentioned before, is a severe life-threatening allergic reaction. And in some cases, we might see no skin findings. So this will be something to report back to babysitters and other people taking care of your kid, that just because they may not have anything on their skin, it doesn't mean they're not having an allergic reaction or anaphylaxis. And anaphylaxis can start with mild symptoms and can quickly progress. Epinephrine, this is the medication version of adrenaline, is first-line treatment of anaphylaxis, and it works quickly, and we'll do a deep dive into that. Now, recently, Rushi Gupta and her team published a retrospective chart review of emergency room visits at Lurie Children's Hospital, where they looked at about 350 cases in total, and they compared the infant population to the older kids. And what they found was that the younger kids, these infants, tended to have more mild symptoms as compared to the older kids. And this is something that has been anecdotally seen. This is something that my team has seen at MGH. This is something that the team with the LEAP study has seen, and many others as well. In her study here, GI symptoms and skin symptoms were seen in the vast majority, while more severe symptoms and symptoms of the respiratory and cardiovascular symptoms were much less common. Their team came up with the conclusion that infants primarily presented with GI and skin symptoms and were having less severe allergic reactions as compared to their older peers. All right, now to take us back a little bit to what's going on and to couple it with symptoms to give you an understanding of what we're dealing with and ultimately what we need to do to treat it. I'm going to take us back to explaining a little bit again, but now a little slower about what's going on. Now, when these mast cells and basophils release what's inside them, these mediators of inflammation can affect the vasculature, blood vessels. What it can do is it can cause something called peripheral vasodilation. It can also increase vascular permeability, which allows leakiness, so you can lose fluid from the intravascular space inside our blood vessels out to the surrounding fluid where it doesn't belong. What it also does is it can decrease the venous tone once it's floppy, then you can have pooling. So if somebody is standing, or if you're holding your baby and their legs are dangling and they have reduced venous tone, then they may not have quite as much blood volume coming back to their heart. What that can do in a little kid, in an infant, is cause tachycardia, a fast heartbeat. Now, these mediators of inflammation also work directly on the heart to decrease the strength, and that also can therefore make the heart beat a little faster. Now, in little babies, we usually actually don't see low blood pressure until way late in the course. The children can have very fast heartbeats. So the babies oftentimes can start with a resting heartbeat of about 130, 140. And if they then start experiencing anaphylaxis, they can get profoundly tachycardic up to the 180s. And we'll talk a little bit about response to epinephrine in these cases. Now, with this leakiness and with this increased vascular permeability, we can then see things on the skin. So as our capillaries and as our blood vessels are releasing what's inside them and the fluid and the other mediators of inflammation, then we could see hives. We could see swelling that's called the angioedema. And that's fluid leaving the intravascular space. So there's this thing called third spacing, and that's pretty much what I've been talking about here, which is when you lose the volume inside your blood vessels and it goes out to the surrounding tissues, and it can be really fast and it can be really profound. So within 10 minutes, somebody can lose 50% of their intravascular volume. Another thing is that when fluid leaves the vessels, if it happens to go in the upper airway, this can start causing some breathing trouble. This can cause upper airway obstruction, and this can cause low oxygen called hypoxia. Now, these mediators of inflammation also work on the smooth muscle of the gut. So that can cause, and I mentioned it before, increase in peristalsis. That can cause vomiting. It could cause diarrhea. And as we already talked about fluid losses, this could make fluid losses even worse. Now, it also can work on the smooth muscle of the lungs, and what that can do is cause bronchoconstriction, bronchospasm, and that can make somebody have a hard time breathing, and that can give symptoms of asthma, coughing, wheezing, shortness of breath. These mediators of inflammation also work on mucus-secreting cells, which then can secrete more mucus, causing more plugging in the lungs. Now, altogether, this can cause more airway obstruction and low oxygen, making hypoxia worse. Now, with the fluid losses from the vomiting and diarrhea, that can make the heart beat even faster and cause more issues with tachycardia and low blood pressure. So what we're going to want to do is be able to recognize anaphylaxis quickly so we can treat with epinephrine and make our babies feel better fast. We'll want to be prepared to react, recognize anaphylaxis, administer epinephrine, and activate emergency response. Call 911 and have an ambulance take the baby to the hospital where they'll be watched for at least 4 to 6 hours. Now, back in 2006, diagnostic criteria were released for the diagnosis of anaphylaxis. As I've already gone through, this feels like it could be a pretty complicated process. And so for healthcare providers, they released this diagnostic criteria. Now, again, this is for the healthcare provider in the office or clinic setting. And you'll notice here that there's a couple of things that we need to take into consideration when using this criteria. First is the presence of a trigger. If we know that there was a likely trigger, it changes the likelihood that this is in fact an allergic reaction to anaphylaxis. If there was a definitive trigger, then it's going to make it a little bit easier to be able to say comfortably, yes, this is in fact anaphylaxis. Other things that are important in this diagnostic criteria are physical exam findings. Now, some of the findings that they ask for require things like medical training, a stethoscope, and things like that. And so this is something where we healthcare providers need to be able to communicate to the families that we take care of a much more simple version, and I'll get to that. And then another thing that you need for this diagnostic criteria are signs and symptoms, as we talked about. Now, if you take a quick look at this, and I'm not going to go over this too long for the healthcare providers on the phone, I would say look into what the diagnostic criteria are. This will be something you'd use in the hospital setting, in the ER setting, in your healthcare provider office, ultimately, you can fulfill this criteria in 3 different ways, and some of them are dependent on the likelihood of a trigger and also the presence of symptoms. Now, one quick, easy way to think of things is if more than 2 systems are present, being respiratory, cardiovascular, GI, skin. If more than one of these systems are present with symptoms, then it increases the likelihood of anaphylaxis, especially in the presence of a trigger. Now, to help with the community management, healthcare providers need to provide emergency care plans to the parents and those taking care of kids with food allergy. Now, the American Academy of Pediatrics has recently released a universal emergency care plan. Now, this is created for all ages, so there's a little bit of extrapolation that needs to be done on the infants because of some infant-specific signs and symptoms and way that they would express themselves, and this we'll get through in the remainder of this talk. I'll have Sally post this somewhere. I think it's already on the Allergy Asthma Network website, and it's on the American Academy of Pediatrics website as well. And having an emergency care plan helps families know when they should be giving epinephrine for the symptoms that their child is experiencing. Now, this is a blow up of what you can find on there. And what they have is that for symptoms that would suggest anaphylaxis, the only treatment is epinephrine, and we'll talk through that in a bit. For symptoms that suggest mild allergic reaction, not consistent with anaphylaxis, then they have observation and the option, if people choose to use antihistamine. Now, for severe symptoms, if a child experiences these in the community setting and they see that on their emergency care plan, then they will get epinephrine because it fulfills the criteria, likely, of anaphylaxis. And one of the things that helps with this is if there is a trigger. So if there's a trigger, for example, the little one is at our aunt's house and they crawl up and they pick up a cookie and they eat it, and we know that that cookie has likely allergen in it, and they have any of these symptoms, then we're going to want to treat with epinephrine. Shortness of breath, wheezing, coughing, paleness, bluish color of skin, weak pulse. Now, this is something that isn't going to be a finding that parents are going to be picking up in their kids. This will be something healthcare teams will be looking for. And in infants, instead of necessarily fainting and dizziness, we might see really weird behavior, loss of consciousness, super drowsy, unable to keep balance. And as far as tightness or hoarseness of throat, we might see a hoarse cry, a loss of voice, not sounding right, trouble breathing or swallowing. We may see excessive drooling, inability to keep the saliva in the mouth or the tongue coming out, swelling of the lips or tongue, vomiting, diarrhea, especially if severe or combined with each other, and other symptoms, hives all over the body, redness all over the body. And in older kids and grown-ups, people can express a feeling of pending doom or confusion, but in kids it might be inconsolability, complete irritability, and we can't get them feeling better. So these will be things that we'll want to look for in the infants and babies. Now, if there's more mild symptoms, and let's say itchiness of the nose or some limited and mild sneezing or itchiness of the tongue, a kid might be scratching at their tongue, or a few hives, especially in areas of contact with food, or a little bit of tummy pain, especially in a kid who is interactive and playful and someone you can engage. Now you're going to be feeling a little bit more comfortable, and observing is still going to be something that you're going to want to do. So now the story would go, you were playing outside near a playground and your kid ate something, and wherever the muffin touched, they had a little bit of rash around their mouth, and you may be nervous, but you're trying to engage your kid and keep your kid as calm as possible. And now you whip out your cell phone and you show them Elmo, and they are laughing and they are playing, and no other symptoms. Then you are going to start feeling more comfortable. You'll be looking at your emergency care plan. You'll have your epinephrine available, and you'll be looking to see if this is going to advance, if there's going to be a change in their demeanor, if there's going to be more symptoms coming. Now, anaphylaxis is like water damage. The longer it remains untreated, the more end organ effects occur, and treatment becomes increasingly difficult. Epinephrine is the treatment of choice. It's first-line treatment of anaphylaxis. Delays in administration are associated with increased mortality, but also the sooner you give epi to the kids, the faster they feel better. Now, epinephrine has effects that take care of all of the symptoms that we just went through. It has alpha adrenergic effects, which are going to tighten up those blood vessels, keep that leakiness, and bring the blood back to the central area. They're going to have beta adrenergic effects, especially beta 2, where that's going to relieve the bronchoconstriction and release those smooth muscles in the lungs to help take care of the coughing, the wheezing, the shortness of breath. And my favorite part of what they do is with the beta 2 adrenergic, it actually can bind to the cell membrane, to receptors on the cell membrane of those allergy cells, and decrease mediator release, and to stabilize those cells, to decrease the chance that they're going to release what's inside them. Back to the analogy of water, it acts like the wrench to turn off that faucet. So if you have a faucet that is spilling out into the tub and it's spilling all over the basement, just running around with a mop isn't going to take care of it. You got to turn it off at its source, and that's what the Epi does. And it works like the mop and the sump pump all at the same time. Now, in the community setting, auto-injectors are the form of epinephrine that can be easily given to a child. There's currently 3 auto-injectors available in the United States: the generic epinephrine from Impax, Auvi-Q, and EpiPen and EpiPen generic from Mylan, and the epinephrine generic from Mylan. Now, as far as dosing for the infant population, Auvi-Q currently is the only auto-injector that has the infant dosing, and they have a 0.1 milligram dosing. Auvi-Q and the generic epinephrine and Mylan and generic Mylan all have the 0.15 milligram dosing for the slightly bigger kids, and also the 0.3 milligram dosing. Now, the American Academy of Pediatrics section on allergy and immunology has now been updating the action plan and a couple other forms of guidance, and at this point is recommending that the epinephrine 0.1 milligram dose be used for kids below 13 kilos. 13 kilos to 25 kilos would be the 0.15 milligram dosing, and greater than or equal to 25 kilograms is going to be the 0.3 milligram dosing. Now, recommendations are to have 2 available doses. About 10 to 20% of kids might need a second dose. The emergency care plans should then reflect that if needed, a second dose can be given. It's also good to have a second dose because if the first goes off into a grown-up's hand or doesn't, for whatever reason, go off into the child, then the second dose can be given. Common side effects are mild: paleness, shakiness. Older kids can express some anxiety. If someone was not experiencing anaphylaxis and had epinephrine, it may increase their heart rate. But in the case of a kid who is experiencing anaphylaxis and is having a fast heartbeat, oftentimes epinephrine actually slows it down and brings it closer to normal. It also can cause some mild headache and nausea. Now, there are no absolute contraindications of epinephrine. So if someone is experiencing anaphylaxis, this is the medicine that they are treated with. Now, healthcare providers will take caution with cardiac issues, arrhythmias, and patients on medicines called sympathomimetics, tricyclic antidepressants, and MAO inhibitors. And this will be something to talk to with your doctor if your child has any of these. And ultimately then figuring out if alternative medicines can be found, and what the approach would be while continuing to have auto-injector available and feeling good about using it when necessary for anaphylaxis. Now, you're going to want to watch out for pockets, buttons, and seams. These things are designed to go through one thin layer of clothing, but especially in an infant, just drop their pants so you see their thigh and you know where you're going. Now, know how to hold your baby. They will be wriggly and squirmy, one thing you can do is know that they're going to have hands that can grab. Now, there can be lacerations if the needle moves while it's in the kid's thigh. Now, the place where you put it is pretty much halfway between the knee and the hip, in the meaty part of the outer thigh, right in the muscle. Now, in the babies, in the little ones, if all that's available is the 0.15 dosing, then being aware of the fact that that needle is a little longer than the 0.1 dosing is important. So with that longer needle length, then a technique to make sure that it goes into the muscle and not the bone is going to be to bunch up the muscle away from the femur, from that thigh bone there, while applying with gentle pressure. Now, in order to do this, if you are holding your baby, imagine that you are sitting down and you have both of your feet on the floor, and you sit your baby's butt. If I'm a righty, so I would sit my baby's butt on my left thigh with their feet dangling between my legs, and then I would close both of my legs around their feet to act like a clamp. So their butt is on my leg while I have their 2 feet in between my legs. I come around them with my arm so their hands can't get in the way of the auto-injector. I take off the safety. I activate the device. I squeeze up their thigh muscle in the case of the 0.15 dose. I find that middle part on their outer thigh and I apply the gentle pressure. For the EpiPen and Mylan generic, you apply gentle pressure and you hold for 3 seconds. 1, 2, 3. For the generic epinephrine, they have not dropped the hold time from their PDR yet, and that's a 10-second hold. And with the AVQ, that is a 2-second hold, and that needle, unlike the other 2 auto-injectors, 0.3 seconds in the thigh, it injects the medicine, and then it self-retracts. So get the trainers. Whatever auto-injector you have, it's going to be fine as long as you are trained on it and you know how to train other people. You're going to need to train babysitters. You're going to need to train other grown-ups who weren't there at the allergy visit. And so for the case of the AVQ and the Mylan generic and Mylan trade, they are giving auto-injector trainers with the prescription. But in the case of the generic epinephrine, you'll need to either ask your healthcare provider or call the company directly or email them and ask them for a trainer so you could get it and you could train secondary care providers. And for all healthcare providers out there, call the company, get a bunch of trainers so you can give it to your families when you give them the prescription. So you'll want to store epinephrine shooting for room temperature. If it is outside and it's the winter, keep it on the inside of your jacket. If it's the summer, don't let it bake and don't let it sit in the glove box because high temperatures can decrease the efficacy of the epinephrine. Now, we'll want to debunk some myths that are out there. So it is a myth that you need to call an ambulance because epinephrine is dangerous. That is not why you need to call an ambulance. You do need to call an ambulance because it was a bad enough reaction to need the epinephrine in the first place, and more treatment may be necessary. So if someone is hypoxic, if they don't have enough oxygen, epinephrine isn't going to work as well. So the ambulance can bring oxygen. If someone is hypovolemic, if they don't have enough volume in their blood, then epinephrine isn't going to work as well. So they might need an IV and they might need fluid to make the epinephrine work better. Now, some people can have a second phase of an allergic reaction called the biphasic, where their symptoms can go away and then come back. And so this is why being in an ambulance on the way to the emergency department where your baby will be observed for a minimum of 4 to 6 hours is going to be important. That catches most of the people who would have a second phase. If there's reasons to keep longer, then that's an important thing to do. So if it was an especially severe reaction, if there were multiple doses of epinephrine needed, if it took a very long time to be treated with epinephrine, these would be reasons that an emergency department may want to observe a kid or admit them for a longer observation. Another myth is to give antihistamines first. Antihistamines do not adequately treat an anaphylactic reaction. They are comfort medicine. And so antihistamines don't take care of the symptoms that we care about. We have a lot of receptors on our skin, so it does a good job dealing with rash and itchiness. But other than that, it takes longer to be absorbed. Epinephrine takes 8 minutes to peak levels, and it gets to everywhere we want to. Antihistamines can take 30 to 60 minutes and also aren't going to take care of the symptoms that we want. So some people choose to include antihistamines on the action plan after epinephrine is given for anaphylaxis, and some providers choose not to include it and may or may not give it in an office setting, and that would be up to the discretion of the healthcare provider and taken with obviously considerations of the family. Another myth is that the needle is huge. The needle is very short. In the adult strength auto-injectors, the 0.3s, the needle is shorter than the diameter of a dime. And then the 0.15, even shorter than that, half an inch instead of 3/4 of an inch, and the 0.1 milligram dose even shorter than that. So to summarize, Epi is first-line treatment of choice. It acts where we need it to. It makes the kids feel better fast. It's fast-acting. Delays in administration increase the severity of the anaphylaxis. And if you're ever in doubt, err on the side of caution and just give it. And remember that it's safe. So thank you very much, and I look forward to your questions.
Oh, thank you so much, Dr. Mike. I totally appreciate everything you had to say. We do have quite a few questions. Our first one is, do you know when the EpiPen will have a 0.1 milligram dosage available?
I do not.
Okay, so the point is right now, the only one available is through AviQ, correct?
Yes, and so for years now, we've all been prescribing the 0.15 dose for the youngest of the children because that was absolutely all that was available. And using a higher dose of epinephrine is way better than using nothing. Now, the dosing may not be the issue. The biggest issue may be the needle length. And on the smallest of kids, the needle length can go beyond the muscle into the femur. Now, in the case of only having the 0.15 available, then this is really the chance of that bad outcome is not a bigger deal than the chance of not treating. So having that available medicine is very important. But the 0.1 is nice because we no longer have to be thinking about that needle length concern, and lacerations would be less likely. And so it makes holding a little bit easier. But notice what I was saying about the 0.15 and the hold technique of bunching up the muscle to bring it up. That's one workaround when you have the slightly longer 0.15 dose. And so for now, when available, the 0.1 is great, especially in the little kids. So a kid less than 10 kilos, that's a kid that I would prefer to use the 0.1 in, especially the youngest ones, because now we're starting to see kids as early as 5 months, 6 months. So a 6.5 kilo kid, that's a kid that I'd prefer to give a 0.1 in. But sometimes some families are unable to get the AVQ, or there's some delivery issues, and then having the 0.15 is adequate.
Well, and I would just like to make the point that neither Dr. Mike or the network is going to endorse any one product. We're simply showing you all of them that are available and discussing some issues, but we certainly don't endorse one product over another. We have another question for you. Regarding early introduction, regardless of high risk for allergies or not, are infant symptoms truly able to digest foods properly at an earlier age?
All right, so the studies are starting to show that the earlier introduction of some of these foods may be protective. And so strong, good evidence for peanut, solid evidence showing for egg as well. And there's been some studies that show that delaying wheat after 6 months may actually increase wheat allergy, that there's also some benefit to dairy early on. And this has been a trend in the research, and more people are trying to put together studies to get definitive guidelines and recommendations. But it does seem that this earlier introduction, as early as 4 to 6 months of life, likely coupled with breastfeeding, may be really great timing for introducing these new foods. So while someone is breastfeeding and you have the positive effects on the microbiome, when these new foods are being added, this may actually be ideal. So it's going to be interesting to see what more of the studies show. But it's it does seem to be that this early time is likely the time that we want to start these oral introductions, but clearly in a developmentally appropriate way where the kids won't choke.
Sounds good. Okay, our next question is, what is the buy-in by pediatricians to this latest evidence for not delaying introductions of peanuts? Do you feel like pediatricians are moving ahead with the new guidance?
Yes, actually, I've given some talks at the American Academy of Pediatrics National Conference, and this year, the folks who attended, almost everyone was aware of them, and they were implementing them and finding them pretty easy to do. Where last year, even people who came to allergy talks, many were not aware of them, and many were finding them very challenging to implement. So I think that this past year, our community has done a really good job of spreading the word and getting out there. And the American Academy of Pediatrics has been awesome, and all our nonprofits like Allergy Asthma Network spreading the word and working with all the healthcare providers. It's getting out there. Some challenges obviously exist because of the need for screening of some. We also don't want guideline creep where people are being overly screened. We want the pediatricians to be screening the high-risk kids, those kids with severe eczema and or egg allergy, and then you can make the argument for IgE-mediated food allergies of other sorts, including dairy. But if the majority of the kids are being fed as per the guidelines, it's going to decrease the bottleneck, and we will hopefully be able to, the allergy community, be able to get the kids in for screening when necessary, do oral challenges when necessary, and get these kids fed or diagnosed with peanut allergy and or other food allergies if and when needed.
Sounds good. We've got quite a list of questions, and we're getting very close to our time, so we'll get to as many as we can. Okay, the next question is the AAP allergy and anaphylaxis plan available in Spanish?
It has been discussed that they are going to be working on it. I don't know if it is yet available, but things are in motion.
Okay, is it okay to use an expired epinephrine auto-injector? Will it still alleviate anaphylaxis until an ambulance can arrive?
Some studies show that even 3-year expired epinephrine is up to 80% effective. So if that's all you got, it's better than nothing. Some things that can decrease the efficacy of epinephrine faster are going to be extreme heat. So the car in the summertime can get extraordinarily hot, and if the auto injector is kept in the glove box, then the chance of that being effective is significantly decreased.
Okay, can patients get flush with epinephrine, or is that from the anaphylaxis itself? This person sees that commonly in young patients.
In my experience, I've seen pallor, so I've seen paleness after epi. I definitely see flushing in allergic reactions, and I'm actually very interested in some of the overlaps between these, and our group is going to be doing studies characterizing infant allergic reactions and anaphylaxis in the food challenge setting and trying to get at some of those questions. So I look forward to finding out more.
Great. Is there a diagram or video on how to hold an infant to give epinephrine?
There is, I do what I just said on, I'm putting in quotes, an air baby in a, on the Food Allergy Center website for my hospital. If you go to the MGH-FC, the MGH Hospital for Children Food Allergy Center webpage, and then look at patient education, there is a food allergy boot camp, and one of the food allergy boot camps was recorded. And towards the end, and if you look at the chapter for giving an auto-injector to an infant, then I go through 2 different ways to hold a baby when giving an auto-injector.
Okay, do you feel there should be a change in the order in which foods be introduced in order to meet targeted age range for early introduction of highly allergic foods?
It is. So this is challenging and an exciting time because there's still a lot to be learned. From my own personal experience in this time where we don't have all that much solid science, with exception of the LEAP study and a couple other well put together studies, what I'm finding very useful, until more people do amazing and good work, I'm finding it really useful to partner with the families and to do shared decision making in what it is that we're introducing. And a lot of what I go by is what the families enjoy eating. And if there's a family that really likes to eat certain foods, especially of the highly allergenic foods, and they're eating it like crazy in the environment, then that might be a food that we want to get on sooner rather than later. And some of the science now is starting to suggest that the Gideon Lack and others hypothesis of 2 exposures, the skin being the sensitizing exposure and the gut being the tolerizing exposure, that seems to be holding some credibility. And so in a family who has lots of skin exposures to their favorite nuts that they're eating in the home, that might be the kid that we want to get that nut on that child in a developmentally appropriate non-choke way, so they see it in their gut before they consistently take it in their skin, especially if they have eczema.
Oh, that's great. Well, we are past our time. If you have a pressing question that did not get answered, please feel free to email me, Sally Schessler. You'll receive my email address and a follow-up email, and I can get your answer for you. But thank you so much for listening today. And please join us next month for our February webinar, when we welcome Dr. Purvi Parikh, who will present on the total lung connection. This webinar will air on Thursday, October 11th at 4:00 p.m. You can register for this webinar on our website at allergyasthmanetwork.org. Look for education in the horizontal navigation bar near the top of the page and scroll to webinars. You can also view all of our archived webinars on this page of our website. At this time, please download the handout from your control panel. If you have any difficulties, please email me using the link in your emails. You can also visit our website for quality guidelines-based resources on allergy and asthma. Thank you again for joining us, and we look forward to having you register to be with us next time on Advances in Allergy and Asthma. This is Sally Schessler for the staff at Allergy and Asthma Network. We hope you have a great and a healthy day as we work to breathe better together.